Good afternoon, everyone. I am Arpita from the IGCP group. We are celebrating the International Cesarean Awareness Month, and the topic that we are going to cover today is Cesarean section, yet another way to get out. And yes, to address this topic, we have with us someone very eminent from this field, none other than Dr. Jyoti Malik, ma'am. It's an honor for me, ma'am, to welcome you to our platform and to introduce ma'am to everyone. She is MBBS, DGO, DNB, MNA, FICS. She's a medical superintendent at JJ Institute of Medical Sciences, Bahadurganj. So, with this introduction, now I would request ma'am to please start with her topic. Over to you, ma'am.
Thank you so much. Thank you, IJCP, for giving me the opportunity to talk on in this month because this is the Cesarean Awareness Month, and actually, the cesarean rate is increasing, and along with that, there are many complications of a repeat cesarean, and the morbidity to the mother increases. So that is why we want to cut down the cesarean section rate, though we all know that cesarean is yet another way to get out. And I would be covering briefly on the technique of cesarean, the steps, the pre-op steps, the intra-op steps, and post-operatively how we take care and the indications and the things revolving around cesarean. So, cesarean, how it originated. So, it started with the birth of Julius Caesar in 10th century, and it was name it was by this in the Greek encyclopedia, the Suda, which reads that for when his mother died in 9 months, they cut her open and took him out. So it was the birth of Julius Caesar with which the name Caesarean comes. And as per Roman law, it was reserved only for women who died during childbirth, so that the woman and the baby could be buried separately, and as a last resort to save baby's life during complicated deliveries. So this is a operative procedure to deliver the fetus through an incision in the abdominal wall and in the uterine wall. An indication, the RCOG says that wherever the anticipated risk to mother and her baby of an alternative mode of delivery outweighs that of cesarean, you should be doing a cesarean. So, coming on to the maternal causes, the fetal causes, and the maternal-fetal causes, the indication are if there's any previous cesarean, abnormal placentation, on maternal request, previous classical hysterectomy, genital tract obstructive mass, invasive cervical cancers, previous any permanent cerclage that has been done for incompetent cervical loss, prior pelvic reconstructive surgeries, pelvic deformities, and any pathology which requires a concurrent intra-abdominal surgery. Not to forget the perimortem cesarean delivery. The fetal indications are a non reassuring fetal status, malpresentations, macrosomia, abnormal umbilical artery Dopplers, or thrombocytopenia. And the maternal fetal indications include the cephalopelvic disproportion, failed operative vaginal delivery, placenta previa, or placental abruption. So the trend of cesarean is increasing, and why it is increasing is because women are having fewer children these days, and thus there's a greater percentage of birth are among nulliparous. The average maternal age is rising. We are using more of fetal monitoring, and when we are using the NSTs, and if it is showing some heart dip, then we trend to going for a cesarean. We are not trying a breech delivery now in many cases of breech presentations. The frequency of operative vaginal deliveries has declined. We are not using outlet forceps. We are not using much of vacuum deliveries because of the litigation. Many of the doctors are scared to go in for a vaginal delivery. The rate of labor inductions is rising. And when there's a failed induction, patient lands up into cesarean. The rate of cesarean deliveries in women with preeclampsias have increased. The rate of vaginal birth after cesarean has decreased. And elective cesareans are now going for maternal request, concern for a pelvic floor injury, and that is why the maternal request cesarean rate is increasing. Now, ART with the IVF pregnancies, neither the patient wants to take a chance, nor the doctor is also very concerned, and that is why the cesarean rate for the ART pregnancies is definitely on the rise. And the malpractice litigations related to fetal injury during a spontaneous or operative vaginal delivery, and that is why the doctor doesn't want to try a operative vaginal delivery, and that is why these are the indications, these are the reasons, actually not the indications, these are the reasons why our cesarean rates have increased. So, what are the talking about the procedural aspect of the cesarean? The timing of the planned cesarean. So, when should we do a cesarean? It should be carried out not before 39 weeks. So, preferably, it should be done anytime after 39 weeks. Then coming on to the time decision to delivery interval for unplanned cesareans or the emergency cesareans, it should be 30 minutes for category 1 and between 30 to 75 minutes for category 2. So what is category 1 is when there is immediate threat to life of woman, and the category 2 is when there is no immediate threat. So in category 1, it should be as early as 30 minutes, and in the category 2, it can be between, it should be between half an hour to 75 minutes. Pre-op testing, they say cross matching, though should not be these days. They say by the NICE guidelines. Previously, we used to keep a cross matched blood, but now the NICE 2019 guidelines said that it should not be routinely offered before cesarean. Coming on to the antibiotics, when we should give antibiotics. Antibiotics should be given at least within 60 minutes before the start of cesarean, or if you have not given, then you should give as soon as possible after the incision is made. Which antibiotic? First generation cephalosporin is the first line antibiotic, and azithromycin can also be added to emergency cesareans. Thromboprophylaxis, since the risk of postpartum VTE after emergency is twice compared to an elective and 4 times compared to a vaginal delivery, low molecular weight heparin are the agents of choice for antenatal and postnatal thromboprophylaxis. Should we do a routine bladder catheterization? No, there is no need. And patients at low risk of intra-op complications, they can void before entering the OT. And if required later on, an indwelling catheter can be inserted intra-op or post-op as needed and then removed. The skin preparation, definitely a pre-op skin cleaning before cesarean with an alcohol-based chlorhexidine alcohol should be done unless contraindicated. Hair removal, no randomized trials assessing this intervention before cesarean have been performed, and if it needs to be removed, then one can go in for clipping or for the creams or for shaving. Vaginal preparation, vaginal cleaning before cesarean should be done, and those with ruptured membranes in both laboring patients also, and those who have ruptured membranes, it should be done using povidone iodine or chlorhexidine gluconate. Now, the enhanced recovery after cesarean, or the IRAC recommendation, they say that you can, when one should start fasting. So, in case of solids, it should be 6 to 8 hours prior to cesarean. They should have that much of fasting of 6 to 8 hours if the patient has taken solids, or if she has taken clear liquids, it is NPO 2 hours prior to cesarean. Also, a carbohydrate drink can be given up till 2 hours prior to cesarean, and it can be like something like a apple juice, which should be taken with no pulp. Anesthesia, regional versus general anesthesia. Regional is better. There's less maternal and neonatal morbidity, though there is risk of hypotension, and preloading with crystalloids should be done. The patient should be given a lateral tilt. General anesthesia, when we should prefer, in cases if there's a severe fetal distress, or there's acute maternal hypovolemia, or there is significant coagulopathy where a regional anesthesia is contraindicated, or if we have given regional and it has failed, or the patient does not want to go in for regional anesthesia. These are the various incisions that we can take. So it can be out of these are the transverse incision. One is this Pfannenstiel incision, the other is the Joel-Cohen incision, and the third is the Maillard's incision. Or you can give a vertical incision. It can be a median or a paramedian incisions. So the Pfannenstiel and the John Coyle are the preferred ones. And what here we give a transverse incision because this is associated with a reduced post-op pain. Also, it has a good cosmetic effect. Now, in Maillard, what they do is they incise, or there's a transverse incision given on the rectus muscle, and rectus muscle and the sheath is cut in this Maillard's incision. So the advantage is that you get a better visualization. The lateral pelvic, the mid-abdomen visualization is better, and you require lesser retraction of the interior abdominal wall. Vertical incisions are superior because you can have a superior access to the surgical field, and there's reduced blood loss, there's minimal dissection between muscle and sheath, but the disadvantage is that there is poor cosmesis and increased post-op wound dehiscence, incisional hernia, and post-operative pain and discomfort. Whether to use a scalpel or electrocautery, you can use both. But in this American Journal of Surgery, it was mentioned that there is no significant difference in the wound infection rates or scar cosmesis, whatever is used, and there's a trend towards less incisional blood loss from skin incision made with electrocautery. Now, reduced incision time, reduced blood loss, and post-op wound pain is there, though there is no significant difference in the wound infection rates or scar cosmesis, whether you use scalpel or you use electrocautery. Then the subacute tissue, you can do a blunt dissection with fingers. That is preferred over sharp dissection, because a blunt dissection is associated with shorter operating time, lesser chance of injury to blood vessels, and less post-op pain. So the tissue is opened from medial to lateral side. After this, the facial layer is separated, and then you come on to the rectus sheath. The rectus can be separated bluntly. You can transect the muscles if you're using a Maillard incision, or you can do the dissection of the rectus fascia from the muscle, though it is thought to be not needed. It is one can just separate that way the muscles. Then the peritoneum you can open by blunt finger dissection, and then all the layers are stretched up to the level of the skin incision. So there's less risk of bowel injury, bladder injury, or to the other organs that are lying underneath. Should we make a bladder flap? Bladder flap, Now, this omission of bladder flap at cesarean reduces the delivery time and without this increasing the morbidity. So you can omit the making the bladder flap. Though some obstetricians choose to selectively perform the bladder flap if a difficult delivery is anticipated, like if the fetal head is deeply engaged in the pelvis, or when the bladder is attached above the lower uterine segment in cases of a previous cesarean section. And in these cases, creation of a bladder flap may help to keep the bladder dome out of the surgical field if your uterine incision extends. So, hysterotomy, prior to making a hysterotomy, the surgeon should be make sure where the placenta is, what is the fetal lie, and in case of a prolonged labor, when the head is deep in the pelvis, the lower uterine segment may be very thin and retracted superiorly. So, it is important to avoid making incision too low because you then may transect the cervix in such cases. So that should be very in case of second stage cesarean. In fact, since the lower segment is very lies underneath this where you should make this incision is just below the bladder peritoneum, where the bladder peritoneum is attached. So various uterine incisions, if you are making these transverse incisions, the risk of uterine dehiscence is much lesser as compared to when you are making a vertical incision, where the risk of uterine dehiscence or the rupture, it goes as high as 4 to 9%, or as compared to 1% in cases of transverse incisions. So transverse has an advantage. It has less blood loss. There's less need of bladder dissection. You can easily reapproximate it, and there's lower risk of rupture in the subsequent pregnancies. That only disadvantage is that lateral extension is not possible, and if it happens, it will risk the major vessels. Now, classical incision you make only if there is poorly developed lower segment, or there's a lower segment pathology, like if you have a large leiomyoma or an anterior placenta or placenta accreta, or bladder is densely adherent, or if you are doing a post-mortem delivery where you want to do a very quick, we need to remove the baby, or in case you have need to deliver a very large fetus. Those are the only indications of classical incision. Or the low vertical incision is similar, as strong as the low transverse, but there is a disadvantage that it may extend upwards towards the fundus and the downwards towards the bladder and the cervix. So you can do either a blunt dissection or a sharp dissection. The advantage of blunt dissection is that the blood loss is much lesser if you are doing a blunt dissection of the uterine, a blunt expansion of the uterine incision. And then transverse versus cephalocod. Blunt expansion of the once you make a low uterine incision, how do you want to expand that incision, whether it should be done transversely or it should be done cephalocodally? The conclusion with this paper was that because this cephalocordal retraction is much better, because there is lesser risk of extension transversely when once we use this sort of a technique. Fetal extraction, how you should do? Fetal extraction should be done very gently. You can use your fingers. The obstetrician's fingers should curve around the fetal head and lift without overly flexing the wrist, and use the lower segment as a fulcrum. Now, difficult extraction could be if there is impacted head, or if it is a free floating head, or if it is extremely low birth weight fetus, breech, or a transverse fetal eye, low anterior placenta, or there's a constriction ring or the Bandel's ring. So these are the two, three approaches. If the fetus is deeply engaged, fetal head, you do a reverse breech extraction, which is known as the pull method, or you can do a abdominal vaginal delivery, that is the push method, where the assistant pushes from below and the operator lifts up the shoulder and then delivers. The baby is pushed up and then we extract the baby. Or the third is the Patwardhan technique, where you remove the shoulder first and then the body, and lastly the fetal head. So these are the various, this is the pull method as the reverse breech, the push method, and the Patwardhan, where the interior shoulder is delivered along with the interior arm, and with gentle traction on the shoulder, then the posterior shoulder is delivered. Then the surgeon holds the trunk of the baby gently with both thumbs parallel to the spine, and with a gentle fundal pressure being given by the assistant, you deliver the buttocks, followed by legs, and finally the baby's head is delivered. So, Patwardhan is a superior, according to this paper. Second stage cesarean, an evaluation of Patwardhan technique. This Patwardhan technique is a superior and a safe technique for delivery of fetus in second stage cesarean compared to the push pull technique. So this is how the baby is delivered by Patwardhan, and then the placental removal. How one should use a controlled contraction method and not use a manual removal, because this reduces the risk of endometritis if you use a controlled contraction method. Exteriorizing the uterus, whether you should do it before exteriorize the uterus. Some surgeons prefer doing that, and they feel the blood loss is lesser, and but it is recommended by NICE in 2019 and also by ICOG that exteriorization of uterus is not recommended, because it is associated with more pain and it does not improve the operative outcomes like hemorrhage and infection. The uterine closure, one can hold the edges with either green Armitage or LS forceps. Identify the lower uterine edge, which is very, very important, because sometimes you can, the posterior uterine part, you can sort of uh, stitch with the upper segment if you are not careful. And the suture material can be anything catgut or vicryl. These days we prefer vicryl, and always place the angle beyond the uterine angle of the uterine incision. Use a running lock suture, and with full thickness, taking the full thickness of the myometrium, and try stitching is as fast as possible, because then you are avoiding the blood loss. Then the key points are that including the decidua may form a tract for infection, and sutures may become loose. So also avoid withdrawing the needle once it has penetrated, and continue beyond the angle of the opposite incision. And the second layer you use for approximation, and a Lambert suture is used for hemostasis and approximation. The uterine closure, single versus double, they say the effectiveness of and safety of single layer closure is uncertain, and therefore you should always close the uterine incision should be sutured in two layers. Closure of classical incision is done by baseball stitches. Unnecessary procedures, cervical dilatation is unnecessary. Uterine irrigation also is unnecessary. Abdominal wall closure, you can close fascia, you may not close it. And then the subacute closure, they say if the routine closure should not be used unless the woman has more than 2 centimeters subacute fat, because it does not reduce the incidence of wound infection. The use of superficial wound drains should not be used because they don't decrease the risk of wound infections. Peritoneal closure, some surgeons omit it, but the advantage they say, those who are doing it, they say you are restoring the anatomy and you are reducing the adhesion formation, you're reducing the wound dehiscence. Disadvantages, they say there's greater post-op pain, greater discomfort, and these reapproximate within 48 hours and demonstrate healing at 5 days. So neither the visceral nor the parietal peritoneum should be sutured at CS, as it reduces the operating time, need for post-op analgesia, and improves the maternal satisfaction, according to RCOG. Muscle closure, post-op muscle strength is better when reapproximation is not done, and unnecessary pain also is much less. Sheath closure, continuous, non-locking, delayed absorbable sutures placed 1.5 to 2 centimeter lateral to the fascial edges and no more than 1 centimeter apart, so that you can give a proper strain to the rectus sheath. Locking reduces the vascularization and slows the wound healing. So, locking should not be done in case of sheath closure. And in patients at risk for wound breakdown, delayed absorbable suture like PDS should be used. Skin closure, you can use anything, mattress, subcuticular, or skin staples. Post-op monitoring after recovery from anesthesia, observe respiratory rate, heart rate, BP, pain, sedation, and these should be continued for every half an hour for 2 hours and then hourly. Pain management, you can give good NSI aids or you these because apart as an adjunct to other analgesics. Wound care specific, you can change the dressing next day, assess for other signs of infection, and encourage the woman to wear loose, comfortable clothes and plan the suture removal after a week or so. The post-op ERAC elements, what they say is early oral intake. So a regular diet within 4 hours post cesarean as tolerated can be started. Early mobilization, ambulation should occur soon after return of motor function. So post-operative, between 0 to 8 hours, she can sit on the edge of bed, out of bed to the chair, and as ambulation as tolerated. Within 8 to 24 hours, ambulation as tolerated. Walk 1 to 2 times in the room or in the wherever she is. 24 to 48 hours post-op, walk 3 to 4 times and out of the bed for 8 hours. So these are the recommendations for early recovery after cesarean. Promotion of return of bowel function, minimize opioid consumption, consider chewing gum. So you can ask the patient to chew gum after 2 3 hours so that there is an early return of the bowel function. Early urinary catheter removal should be removed by 6 to 12 hours postpartum. Construct protocols to establish criteria for appropriate removal and to manage post-catheter removal urinary retention. Venous thromboembolism prophylaxis, one should follow the ACOG and ACCP guidelines. So, early discharge, you facilitate, so you standardize the discharge planning, coordinate care, should start pre-operatively, use metrics to monitor the patient progress in meeting early discharge. Anemia, screen and treat anemia, and one should have a good, robust lactation support as per the institutional guidelines. So, complications, one, the primary maternal mortality is 4 times that of a vaginal delivery, could be due to shock, due to anesthetic complications, and hemorrhage could be due to atony, DIC, adherent placenta. Injury to the bladder can happen, especially if there is the patient is in advanced labor, or there is a previous pelvic surgery, cesarean, or secondary to uterine laceration. Post-operatively, there could be early in the early part, post-spinal headache is very common. Paralytic ileus can happen. Thrombosis and pulmonary embolism, 4 to 16 in 10,000 cases. Wound infections and burst abdomen can happen if the patient is anemic, if she is not built properly, or she has infections, abdominal infection, chest infection, and basal atelectasis can happen if she is not getting up early. Rupture of uterine scar during subsequent pregnancy is one of the late complications. Chances of adherent placentas are becoming very common, 4 to 8 per thousand in cases of previous cesarean. So, if it is a low lying placenta and in a previous cesarean, you should be very, very careful about placenta previa and mal adherent placentas. Incisional hernia is another thing which can happen post operatively in cases of multiple cesareans. So these are the so this is this was the last slide. So thank you so much for listening to me patiently on this very, very important topic of cesareans. And these were the techniques, the indications, the post-op intra post-op way how to handle it, and the complications that can occur later on. And if there are any questions, I think we can take those questions.
Thank you, ma'am. First of all, I would like to thank you for such an insightful presentation. It has covered almost everything. I think nothing is left there. Still, let me see if there are any questions from audience.
Okay.
Yes, sir. Ma'am, the first question is, given the rising global cesarean rates, what key factors do you believe are contributing most to this trend in India, especially in urban versus rural setting?
Actually, I think the patients are not that sort of, they are not, they don't, the endurance is not there. They feel they are not able to, the pain, I mean, their pain threshold has become quite low these days. Maybe they are not very active, so that could be one factor. Because if you are physically active throughout your antenatal period, it helps a lot in making your pelvic muscles supple. And you should do a lot of pelvic floor exercises, stretching, squatting, so that the pelvis, in cases of primey, actually, if it is only basically the nulliparous patients. So if she's a primey, she should be very, very active. Then only I think we can avoid cesareans. And they also, we can give labor analgesia so as to make them to take care of their pain. Many indication the patients feel they cannot tolerate the pain, and that is why they opt in for cesarean deliveries once they go into active labor. So if you can give them a good labor analgesia, if you can give them a partner during the labor time, with one who can be sort of can console and can give them that strength. So then the cesarean rate can decrease.
Right, ma'am. So, ma'am, related to your point, there is another question. Like, ma'am, how important is antenatal counseling in shaping a patient's choice regarding the mode of delivery?
Can you repeat the question? Actually, I could not hear it properly.
Yeah, ma'am, how important is antenatal counseling in shaping the choice of a woman regarding the mode of delivery? Ma'am,
It is
antenatal
very
counseling.
important because they should be mentally. Yeah, yeah, it is the more very, very important aspect, and it can definitely help the patient go through that part of labor very easily if they are convinced that the patients who say they would like to have a vaginal delivery, what come may, and they are ready for it, they are mentally right from the beginning, they are mentally preparing themselves that way, and it pays a lot, it does help a lot.
Right, right, ma'am. Another last question, that is, how do you suggest clinicians strike the right balance between respecting maternal request and ensuring cesareans are only done for medically justified reasons?
Yeah, so it is very nice suggestion and very nice comment actually. And so many patients on demand they are asking for cesarean. So it is always a good idea to tell them that okay, one cesarean is okay, but the next cesarean will can be very very difficult, and one can tell them about placenta previas, the placenta accreta, the morbidity associated with cesareans. So the patient becomes more aware that what if they are choosing a elective cesarean on demand, then the complications can happen in their next deliveries. The chances of the second cesarean increases. Vaginal birth after cesareans, the incidence is quite high because these days the patients, the many of the doctors are doing a single layer closure, and that is why the wound strength or the uterine strength is not that much. And when we are operating and when we see these patients, the lower segment is very very thin, even if they are not in labor. In second elective cesareans, the lower uterine segment is so thin that next time we also feel that it becomes should we it was good that we did elective cesarean. Had we given them a trial, maybe the scar would have ruptured. Seeing that is what we retrospectively, once we open the abdomen and when we see the uterine scar, then that time we feel okay, good, it was good that we did a elective cesarean. So definitely vaginal birth after cesareans are increasing, because of the vaginal birth after cesarean are decreasing, the cesareans, the repeat cesareans are increasing.
Right, ma'am. Ma'am, one last query. Since you are the medical superintendent of such a prominent institution, so are there any practical steps that you and your healthcare institution are taking in order to promote vaginal birth after cesarean?
After cesarean,
Yes,
see,
ma'am.
vaginal birth after cesarean, it is always better to prevent the first cesarean, then only we can reduce the cesarean rate. So we should be very judicious in deciding. We some of the patients, even when they are not in active labor, they are even in the latent stage, and we say okay, it is 6 8 hours and let's go in for a cesarean. That is not what we promote. We should never do that. Let the patient be in active labor, and then only one should decide okay whether she is going into non progress. So we have various criterias, and according to that we should decide that whether this patient actually needs a cesarean. So that is something very, very important, and that is why we should decide that
Right, ma'am. Thank you so much, ma'am. These were all the questions for today. And before wrapping up, I would like to thank you, heartfelt thanks to you, ma'am, for sharing your insightful thoughts and such a thought provoking presentation on this very important topic as we are covering the International Cesarean Awareness Month. Ma'am, your expertise and balanced perspective on evolving trends in cesarean delivery have truly enriched our understanding. So, with that note, I would like to thank also our audience for taking time and participating. Thank you once again, ma'am. Thank you once again for your valuable time. Thank you so much.
thank you IJCP and the complete team, and thank you Arpita. It was a
Thank you,
pleasure
ma'am.
to be here and talking on this important topic. Thank you.
Thank you, ma'am. Thank you so much.